Welcome to the discussion of pathogenesis and treatment of cardiac and circulatory conditions. I'm Dr. Carricker. I'll be leading us through a series of discussions and a glimpse into some of the pathology pertaining to the cardiovascular system. We'll start with some diagnostic tests for cardiovascular function, and some of these will provide a little bit greater detail. Certainly we have electrocardiography, echocardiography, auscultation, and also exercise stress testing. Now, when we talk about some of these different techniques, they are meant to highlight the methods that we can identify pathology in the body. And electrocardiography, as an example, is useful in the initial diagnosis and monitoring of various dysrhythmias, including myocardial infarction. In some indication, we can get a glimpse into the heart, a window, if you will, and identify perhaps infection or inflammation of the pericardium, for instance, pericarditis. So all of this can be identified based on the way that the heart rhythm manifests and the way that we can record it and take a picture of this. And then the doctor or physician, the cardiologist who's analyzing and looking at the 12 lead can identify on this rhythm strip where the dysfunction in the heart may be occurring. So I just quickly want to highlight to make sure that we're on the same page. This would be a 12 lead rhythm strip. I want you to ignore below this line that I'm creating. This would be a continuous rhythm strip. This is lead 2. It's actually also lead 2 right here. But you'll notice this lead 2 stops right here. So this, below this imaginary line that I'm drawing, is a continuous rhythm strip. Now the blue dots and the red line, those have just been added for illustration purposes. Those wouldn't normally show up when you do a line, but the blue dot would be indicating the P waves. Okay, and everything touching the red line occurred at a simultaneous point in time. So just very quickly, this would be a 12 lead rhythm strip minus this continuous lead that you see across the bottom. So here's the 12 leads. Lead 1, lead 2, lead 3, AVR, AVL, AVF, and then we have our precordial leads, V1, V2, V3, V4, V5, V6. So these 12 leads correspond to different areas in the heart. And of course, if we look at where an electrical signal has an aberrant or rhythm that's not in line with that normal electrical pathway, that may give us an indication of where on the heart that dysfunction is occurring. For instance, where a heart attack is causing cell death or myocardial infarction. So given our understanding of a 12 lead and given the understanding of the regions impacted, that might help a physician when they go in to do some other diagnostics, for instance, looking with echocardiography, or whether they're doing some type of analysis with placing a catheter and trying to identify where a blockage might be. The first picture that they get of the electrical system is going to give a great indication of where that pathology may be on the heart. Now, this is an invasive, this is a non-invasive procedure, just looking at the electrical activity, because we just place electrodes on the surface of the skin, and then we can analyze the rhythm, and we see this then printed out on a computer screen or printed out on a piece of paper on a rhythm strip. Now, in some instances, it may be necessary to monitor EKG or ECG changes throughout the day. And so a person may be asked to wear something like a portable Holter monitor that they can then continue to pursue activities of daily living, but the box that they're wearing maybe around their waist, like at a belt or a fanny pack, is going to be recording the ECG throughout the day. And so then, if a person experiences chest pain, they might be able to press a button and give them an indicator or a mark in time saying, this is when I felt palpitations, or this is when I started to feel a little bit nauseous or had chest pain. And then when they go back to the doctor's office, they give them back the monitor that monitor can then be analyzed over the 24-hour period. And if there are event indicators input by the patient, then the doctor can kind of quickly identify what was going on at that point in time. So a lot of different things can come from electrocardiography. We also have ability for auscultation. Many of us are familiar with various different lung sounds that we can listen to, but we can also listen to sounds of the heart and how the heart is beating. So we might be listening, for instance, by location of the stethoscope placement at different valves. Maybe we're listening for heart murmurs, right? Valvular abnormalities, or abnormal shunts of blood, like a whooshing sound that we might hear. So here's a pathologic example of heart murmur. And so essentially we'd have this displacement of one or both leaflets. Let's say we're on the left side of the heart, the mitral valve. And some of you are familiar with the term mitral valve prolapse, and others are familiar with the term heart murmur. In this case, they mean the same thing. So we're looking at this dysfunction of the heart valve, and it is occurring with the leaflets extending or displacing beyond the annulus into the left atrium. In other words, it's kind of pushing backward. It's reflected backward. It's not closing the valve like it should be, which is allowing blood to regurgitate or leak backward from the ventricle into the atria as the ventricle contracts. We know that as the ventricle contracts, blood should be traveling out the aorta. In this case, it's retrograde blood flow. It's traveling back to the atria. Some of it, not all of it. So some blood is getting out to the systemic circuit. But we would say, because not all the blood is getting out, there is a reduced efficiency of the heart. And if we talk about ejection fraction, and we talk about some of the characteristics for heart failure and how that might manifest, right? Heart murmur could be one of the initial things that's causing some of these challenges. So let's take a look at the etiology, right? What is causing a heart murmur? And essentially the heart murmur is that rushing of blood in the wrong direction from the ventricle backward to the atria. Well, it could be due to mitral valve prolapse. That tends to be the most common cause, etiology, of heart murmur. And this is most common in athletes, and it may be due to the stretchy valve leaflets. Now, this particular disease, right, may have electrocardiographic findings. And so again, if we're looking at an EKG, we might show T-wave changes. And these electrocardiographic abnormalities, which are noted primarily in an inferior limb leads, again, looking at leads 2, 3, and AVF of a 12-lead ECG, might show us that there's a consistent type of inversion of the T waves, or this is occurring with the absence of ST segment depression, which might be an indication of some progression of some heart problems. So these abnormalities may be evident in some of the left precordial leads as well. If we're looking at our area in, let's say, V5, V6, perhaps high lateral, maybe even extending to lead 1. But depending on where this abnormality is occurring, gives an indication of maybe there's a problem on the left side of the heart. So again, if abnormal T waves are noted on a routine electrocardiogram in a young athlete, well, mitral valve prolapse should be kept in mind in the differential diagnosis. But we also need to keep in mind that sometimes biphasic or negative T waves are not uncommon in an athlete, and it's not necessarily due to mitral valve prolapse. So in other words, it's not pathognomonic where it's, we see this, it's absolutely this, but rather it's something that if we identify something on an EKG, let's keep the antenna up, let's keep the radar, let's calibrate the radar and say, look, let me listen in, or let me try another diagnostic technique. So we might look at auscultation, or we might look at maybe an echocardiography to get a better picture. But certainly, going back to our figure here in terms of some other causes. Certainly endocarditis and connective tissue diseases, rheumatic heart disease, coronary artery disease, dilated cardiomyopathy, all of these can cause a heart murmur. So some of the symptoms that may manifest in a majority of patients, well, they could remain asymptomatic. A person could have a heart murmur for many years undiagnosed. And oftentimes the diagnosis may be even made accidentally on just a routine physical exam where the patient doesn't present with any problems, but this disease has been present for many years. Now, in some cases, that may occur because the participant never really participated in activity. So there never would have been a reason where the heart rate is elevating and losing efficiency, and we start to feel, weak and unable to participate in high levels of physical activity because maybe the body was never challenged to that degree. And so the heart murmur wasn't really impacting the normal routine of physical activity because there was no normal routine. Now, we should keep in mind the rate of sudden cardiac death in athletes is 2 per 10,000 per year. I like this article, came from the American College of Cardiology. I'm just going to read just the opening paragraph here to kind of give an indication. Recently published 2017, mitral valve prolapse and mitral valve regurgitation in athletes. So again, as we've mentioned, and I'm reading here from the paragraph, there are many causes of mitral valve regurgitation, including mitral valve prolapse, infective endocarditis, rheumatic heart disease, connective tissue disease, coronary artery disease, dilated cardiomyopathy. And mitral valve prolapse is the most common valve abnormality in the general population, affecting 2 to 3% of people. So, this would be an article where if you're interested in learning more about this, you might dive into it, go find it on your own and read into it. But in 2015, the American Heart Association and the American College of Cardiology released the following recommendations regarding athletic participation for patients with mitral valve prolapse. So in athletes with mitral valve prolapse, but without any of the following features, really they can engage in competitive sport. If we don't have an athlete that elicits syncope, if we don't have an athlete with sustained or repetitive or non-sustained supraventricular tachycardia or frequent ventricular tachyarrhythmias, especially those noted on ambulatory Holter monitoring, which we addressed in our initial set of slides, severe mitral regurgitation, left ventricular systolic dysfunction, prior embolytic events, or family history of related sudden death, then our athletes should be able to participate. So athletes with mitral valve prolapse and any of the aforementioned diseases should and could participate in low-intensity competitive sport, okay, if they had any of those problems. So it's not to say that an athlete can't be active, but if they had any of those problems, then we need to keep their intensity low. Right? If they don't have any of those problems, then we can really engage in all competitive sport. Okay, so we'll keep this in mind that as you're working with your athlete, as you're talking with your athlete, they're getting recommendations from their physician, and that should be who's driving the conversation to say, what am I able to participate in, or what type of activity can the athlete undergo? Now, while sudden death from this mitral valve prolapse is rare, okay, it's possible a larger number of patients with sudden death go unreported, not knowing that they had mitral valve prolapse. Because not everybody that has it is going to be symptomatic. And maybe they weren't symptomatic until they engaged in a high level of sport, which caused a profound problem leading to death. And so their cause of death, as termed of mitral valve prolapse, maybe was never identified as such. Now I present some Chicago Marathon deaths where we had a 35-year-old and a 29-year-old physically fit male and female. And you can see that in reality, marathon runners tend to be pretty healthy if they're engaged in that long duration of physical activity. They've obviously done some bit of training, but deaths are still a possibility. So we should have we just have a background of our athletes, health history, make sure that we're understanding who they are, what ailments they present with, what ailments they come to the table with, so that if something occurs on the field, we have some background as to maybe what may have caused some of that complication. All athletes with mitral valve prolapse should have an annual follow-up with a cardiology monitor to determine if they have high risks. And certainly if there's a progression or if there's a worsening of this ailment. Now, some of the other diagnostic tests that I opened the slide set here with, one was echocardiography. And certainly this could be used to identify and record heart valve movements. It can also be used to look at ventricular wall movement, right? So not only, just like we're talking about, is a further diagnosis of the mitral valve, but it could also be used to identify, if there's poor apical wall movement or poor contraction. If we added some contrast dye, we added some ability to then look at ejection fraction, we could identify the bolus of blood returning into the heart, and then identify how well the heart was able to pump blood out. We could also identify and see if there's retrograde blood flow, and certainly identify, if there is a complication, for instance, mitral valve stenosis. So here we have a picture of a normal mitral valve and then a narrowed mitral valve. So if we were looking at this echocardiography being this diagnostic technique, we might be able to identify some pathology. One example being that mitral valve stenosis. And obviously that stenosis or blockage of this mitral valve, which is highly important for allowing blood to flow from the left atrium into the left ventricle, and then also, closing blood off so it's not retrograde or flowing in the reverse direction. But the cause of mitral valve stenosis, the etiology, in many cases rheumatic fever could manifest with this particular ailment. Congenital mitral valve narrowing and calcium deposits around the valve, these can all be problems that may manifest. So again, another diagnostic technique. Well, one of the final diagnostic techniques that might be used to identify cardiovascular problems would be exercise stress testing. And we have indications for testing to encompass 3 general categories. Why would we be doing this testing? Well, number one, we might do it for diagnostic purposes to determine, is a disease present? Or at a given level of activity, is there an abnormal physiologic response? In some cases, let's say a patient's just had heart surgery and they're now in cardiac rehab. Prior to return to work, they may be asked to do an exercise stress test to stress the body to the intensity that their work demands. Maybe they're a construction worker, going to be doing a variety of walking and lifting and moving, elevating the heart rate, and they want to know, before we clear you to return to work, are you going to be able to do the level of intensity that your work demands? Or is that level of intensity going to initiate resurgence of angina or some other type of maybe electrical arrhythmia? It could also be done for prognostic measures in terms of evaluating risk, and then certainly evaluation of physiologic response to exercise. So looking at blood pressure response or peak exercise to determine if at a higher level of physical activity, do we have a manifestation of electrical problems? Are there multiple or frequent premature ventricular contractions or PVCs? Do we have a run of 3 or 4 PVCs in a row where we might be indicating, well, now we have some type of tachycardia that results? Or is it something that, yes, does occur, but it's very infrequent? We have less than 5, 6, 7, 8 in a minute. It's not going to impact cardiac output. It may just be something that happens but isn't problematic. So we might have the patient come in, connect them to an EKG. We're running an impedance test here on the EKG, have our participant hooked up. We can be looking in this case at 3 different leads or 12 different leads or 1 different lead. In this case, we've got 2, V2, and V5. Plugging in the blood pressure here, getting ready at rest. And now we start the participant exercising, asking the participant not to hold on to the front bar, but just walk normally. Again, during exercise, we're able to evaluate some of the electrocardiographic changes that occur, getting a heart rate, taking a blood pressure during physical activity. All of the following giving an indication of, is there a dramatic rise in blood pressure during exercise? Is there a fall in blood pressure during exercise? Does the patient feel any chest pain? Is there undue fatigue that results? And so here we have, participant here is in stage 3 of a Bruce protocol. We've recorded blood pressure, heart rate up at 170, and we'll go now into recovery. Okay, so that may have been the end of the test. The patient may have said, I have chest pain, we need to stop, or it may have just been a predetermined endpoint. Look, at this level of intensity, that's what we needed to know. We'll go ahead and conclude the test there. So there might be a number of reasons that we have a standardized endpoint. It may be a symptom-limited endpoint, or it may be volitional fatigue, going to the end of max capacity, right? If we're looking at a maximal exercise treadmill test. So this particular figure comes out of the American College of Sports Guidelines for exercise testing and prescription. And you can see there's some contraindications to symptom-limited maximal exercise testing. In other words, why we would not participate in symptom-limited max testing. Some of them are absolute and some of them are relative. The absolute indications would be just that. If these are present, do not pass go, do not collect $200, do not do symptom-limited maximal exercise test. We also have some relative contraindications, and in these relative contraindications, does the risk outweigh the benefit? The information that we're going to gather, the information that we're going to get from doing this test, is it more important than the risk that would be associated with doing this level of activity? So I'll let you read through some of those, but again, these would be contraindications to symptom-limited maximal exercise testing. We also have some cognitive skills required to competently supervise exercise tests. In other words, the technician who's going to be helping to run this test needs to have a knowledge of a variety of different areas, including a knowledge of some cardiac arrhythmias, the ability to recognize and treat serious arrhythmias, knowledge of some cardiac drugs, certainly if patients are on current drugs, how that would impact some of the exercise performance, hemodynamics. The technician has to have a certain level of understanding of potential problems and also how to mitigate or reduce some of those. So best practices for monitoring during a symptom-limited maximal exercise test, again coming from this guidelines for exercise testing and prescription from and based on recommendations from the American College of Sports Medicine, we would look at variables of electrocardiography, heart rate, blood pressure, signs and symptoms, and that could be signs and symptoms in terms of how the person feels, chest pain being one of those examples, and then also rating of perceived exertion, so how difficult the level of activity seems. And you can see when we would measure these and how frequent and how often we would measure these, both starting before the test to get a baseline, during the test, how often, and then after the test, how long we would continue to measure some of these variables. And then certainly we have to understand, and we should understand, indications for terminating a symptom-limited maximal exercise test. If any of these absolute indications show up, stop the test. If any of these relative indications show up, what's the purpose of the test? Is the relative indication for terminating this test, does that supersede the benefit? Or is the benefit, does that outweigh some of the relative risk? For instance, a reason a benefit might outweigh is maybe the physician needs to know You had this stenosis, you had this block, we went in, we placed a stent, we removed it. Is that still causing problems? We have to go up to the symptom limited intensity where you previously had problems to identify and determine, did the intervention that we, surgical intervention that took place, did it resolve the clot? Did it resolve the symptoms that we were seeing? Maybe they were doing cardiac ablation therapy, where they were, the patient had some type of aberrant heart rhythm where it was generating from outside that normal electrical conduction pathway. In this case, does that electrical problem still occur? Does it still manifest? Well, we might have to elevate intensity and proceed with some of these relative indicators to determine, does that still show up? So again, certainly things that we'd want to understand in terms of absolute and relative, and then what's the purpose of our testing. And then there's a number of different additional diagnostic tests. Not all of these we'll go into with great detail, but certainly diagnostic testing with chest x-rays could be used to show the shape and the size of the heart, looking at cardiac catheterization, looking at measuring pressures within the vessels, looking at valvular and heart function, determining central venous pressure and pulmonary capillary wedge pressure, identifying how well is blood flowing from the right side to the lungs, from the left side out the heart. During diastole, is there adequate filling of some of these coronary vessels? So a lot of different methods that would occur. And then certainly angiography being another example of visualizing the blood flow in the coronary arteries. So coronary angiography is a procedure that uses a special dye or contrast material, and then we can use some of these imaging to determine how blood flows through the arteries in your heart. So they might inject this contrast dye, and in this test, obstructions to blood flow could then be identified and treated with other cardiac catheterization procedures, including injection of thrombolytics, so agents that are intended to break down the clots, or placing stents, or balloon angioplasty, or methods to open up a narrowed coronary artery mechanically. And in this picture, we see the arrow indicating where, if the technician or physician who's doing this contrast dye angiography looks and sees this image, where the arrow is, you can see definitely some type of narrowing of blood flow through that region. So that might immediately give the physician an opportunity to say, it looks like that's where we have stenosis, or that's where we have this clot. That's where we need to focus our attention in terms of resolving some of the issues. Now, a patient like this with a clot in what would seem to be, in this perspective, a rather large coronary vessel may have significant chest pain. That may be the cause of why they're in the hospital to begin with. And so these techniques can certainly be used to help identify the location of blockages. Now, some other things that you might see is Doppler. And Doppler would be looking at assessing blood flow. And typically this is done during diagnostic ultrasound testing, where we'd have some type of microphone. And down here, now this would be ultrasound. Okay, so what we're looking at is now ultrasound technique. That's this one here. And we're looking at a brachial artery. So this area right in here, this would be the open patent brachial artery. And what we've added down here would now be Doppler. And so now this Doppler that's added to the bottom of this ultrasound imaging helps to identify some of the measured sound waves, which gives an indication of the way that blood is flowing through a vessel. And this can help to identify some of the blood flow. And the rate of blood flow may be highly indicative of some of the hardening of the vessel or the problems. If we have a high blood flow versus a low blood flow would indicate more compliant vessels that as a bolus of blood clumps through, they're kind of able to open up and expand. A harder vessel or a harder artery, one that's less compliant, is going to have a higher blood flow because as that bolus of blood goes through, the vessel doesn't really open up and expand, but rather it stays very hard and narrow, and that blood is going to travel at a much quicker speed. So again, combining some of these diagnostic tests together allow us to have a better understanding of what's going on in the body. And there are certain blood tests that can be indicative of cardiovascular pathologies. For instance, and as we'll talk about later in this lecture, troponin blood tests, which might be looking for elevations of blood proteins, specifically troponin I, which might be elevation in response to a chief complaint of chest pain. Other markers like creatine phosphokinase, and we'll talk about some of that as we go forward. But that creatine phosphokinase may not only be elevated due to chest pain or some other type of heart problem, but it could also be elevated due to rhabdomyolysis, certainly heart disease, but maybe also kidney disease. So a number of different things, and then certainly arterial blood gas determination, checking the current oxygen level and acid-base balance can all give us an indication of how well the heart is circulating oxygen and blood throughout the body. Now we have some general treatment measures for cardiac disorders. Certainly a physician may recommend certain dietary modifications, maybe even recommending a person see a nutrition. We look at some techniques to decrease total fat intake, general weight reduction, so there might be a caloric problem, and then reducing salt intake, and some of us are familiar with a DASH diet, a dietary approach to stop hypertension, and different vegetables and foods that would be incorporated into that type of diet. Regular exercise programming, certainly the push is with physicians recommending physical activity instead of pharmacologic therapy if that's possible. In the instance of exercise programming, certainly increasing high density lipoprotein levels, lowering steroid lipid levels, like your LDL values, lowering total cholesterol, and reducing stress levels. Those can all be important. Recommendations of cessation of smoking. Drug therapy, gosh, there's far too many drug therapies to mention in one slide, but we might be talking about vasodilators to reduce peripheral resistance, maybe beta blockers to treat hypertension and other dysrhythmias, calcium channel blockers. Those are obviously changing and decreasing cardiac contractility, because we know calcium has a large, strong role in initiating some of the contraction. Digoxin for heart failure, antihypertensive medications to lower blood pressure, ACE inhibitors, right? Angiotensin converting enzyme inhibitors to block conversion of angiotensin 1 to angiotensin 2. Patient may be placed on diuretics to remove excess sodium in water, because that might be necessary to treat high blood pressure or congestive heart failure. If a patient's at risk of throwing clots and at risk of stroke and other types of areas, we might have anticoagulants that are administered. And then certainly, cholesterol lowering drugs. So there's so many that, in terms of a drug therapy, what avenue are we hitting? And we're probably not taking a cocktail of all of these, but we're probably getting prescribed in some instances one, two, a combination of these drugs, or if we're early on in our diagnostic assessment, maybe regular exercise and dietary modifications might be the best way to go. Okay, let's look at some pathology here. Arteriosclerosis and atherosclerosis. Looking at arteriosclerosis being this loss of elasticity, very common among individuals over age of 50. We use this general term to describe all types of arterial changes. Arteriosclerosis. Degenerative changes in small arteries and arterioles, loss of elasticity, the lumen gradually narrows, becoming obstructed. Now, it is in large part a cause of increased blood pressure. Now, arteriosclerosis is differentiated from atherosclerosis by the presence of these atheromas. And in atherosclerosis, the presence of these atheromas in large arteries, which causes plaques to build up and essentially harden the vessel wall. So these plaques form inside the vessel walls and may cause this hardening of the artery, and that obviously causes some change in the way that the blood is moving. And if that plaque completely occludes the vessel, well, we have blocked blood flow. And certainly blocked blood flow, everything distal to that area is no longer getting adequate oxygenation, and in some cases, if that's particularly in a coronary vessel, we might end up with cell death, myocardial infarction of areas distal to that clot. So these are all important, physician looking at making recommendations related to diet, exercise, stress, all these are going to be important in terms of changing our lipid, combination, with low density lipoproteins, the lousy stuff, or high density lipoproteins, the happy stuff. Obviously trying to change their composition to reduce some of the buildup of clots and plaques. And then obviously we have some causes of atherosclerosis, certainly risk factors that are non-modifiable, like age, sex, genetic, or familial factors. Some other things that are modifiable, obviously obesity, sedentary lifestyle, cigarette smoking, you could read the rest. But certainly understanding that some of these modifiable risk factors we need to address with the patient. They may not be aware that these are risk factors. And so if we've got an athlete, if we've got a participant who is at risk for some of these vascular problems, maybe we also need to provide them with education that some of the risk can be mitigated with a healthy diet and dose of exercise. Now, this progression here of atherosclerosis indicates that it may start with some type of damage to the endothelium. And this damage to the endothelium causes obviously some problems where we now, because of that damaged endothelium, where we had this endothelial injury and local inflammation that arises, particularly you'll hear C-reactive protein and initiating, obviously if we have inflammation, we're familiar with some of our process there with white blood cells, monocytes, macrophages, all coming to this area to kind of resolve the damage, right? To resolve the problem. The problem can be if lipids accumulate in the intima or media. We're talking about the tunica intima and the tunica media, and then the outer layer would be the tunica adventitia, but the two inner layers of the vessel wall could end up with fatty lipid development. And that's what we see happening here in panel B. And so obviously smooth muscle cells proliferate and multiply, but if we have this plaque form and we have this inflammation that persists, then these platelets are going to adhere to the damaged surface of the arterial wall, forming a clot or a thrombus, and obviously creating some type of partial obstruction. And that's what we see beginning to occlude this vessel. So we've still got adequate blood flow, but this beginning of the occlusion can certainly manifest and cause greater problems. Now the lipids are going to build up in this area and fibrous tissue is going to form, and that's what we see happening here. And as the platelets adhere and release prostaglandins, and we have this vasospasming that occurs, it causes more platelets to aggregate. And it enlarges the thrombus, and now we have this fibrous plaque that develops. And unfortunately, we can have some issues here where we have a complete lesion, or this damage that occurs. And in this case, the red part's this thrombus, the blue part's collagen. We have a blockage where now we have inadequate blood flow to the distal tissue. And this can certainly be problematic, especially if this clot breaks off and travels to other areas. It travels to areas of the heart. It travels to areas of the lung. Talk about pulmonary embolism. Traveling to the heart, we're talking about block that causes angina or myocardial infarction and cell death as a result, right? So a lot of different things. Now, certainly we're talking about the narrowing of large arteries by cholesterol, okay, and plaque and thrombus. And we have this partial obstruction leading to a complete obstruction. Now, certainly areas of the heart, the brain, peripheral arteries, the legs, these are all areas which can experience problems. So if we have these atherosclerosis develop in the heart, we might end up with chest pain. Total occlusion, cell death, right? In the brain, we might end up with a stroke or some type of transient ischemic attack, something that's temporary, versus maybe we have now cell death and a cerebrovascular accident. Or we have some other type of problem like an aneurysm or peripheral vascular disease that, again, causing a reduction of oxygenation downstream could lead to gangrene and leading to complications that would have an infection that may begin to spread, make its way into the blood, sepsis, which would kill you. So amputation may be a treatment that may be necessary. And for some of this vascular treatment, we've talked about many of these already, with diet modification and change in sodium intake and controlling blood pressure, engaging in exercise, stop smoking. And in some cases, we might have a surgical intervention where, depending on where that blockage is, we may have to have some type of coronary artery bypass graft if the block was in the heart, where basically because of this blockage, we're basically going to bypass the blockage. So we would take a section of vasculature from the leg, and that section of vasculature would then be placed surgically in the heart, so that here where we have this block, we now bypass the block. And even though this blockage still exists, we have this secondary avenue which alleviates some of the problems that would otherwise manifest. So looking at cardiovascular pathologies, we have this progression and obviously understanding how this change occurs. Let's start with this term, acute coronary syndrome. It's this umbrella term. It's used widely to discuss situations where blood supplied to the heart muscle is suddenly blocked. It could be for a number of different reasons, but the pathophysiology there is progressive narrowing of the lumen of the coronary arteries. Now, the severity of the narrowing is dependent on the location, right? Are we blocking a large artery in the heart, serving a large amount of tissue, or are we blocking a really small vessel that's, a network coming off of a large artery, such that the tissue that is fed by this smaller artery isn't going to cause a significant disruption in function? Right? If we're not causing significant disruption to the left ventricle, then we may not have issues with blood outflow, as an example, right? And so this acute coronary syndrome includes stable angina and unstable angina, and in some cases acute myocardial infarction. But if we break down these two terms of acute coronary syndrome, we're looking at stable angina and unstable angina. So stable would be something that is temporary, transient, episodic, and it would result from decreased blood flow to the heart muscle. Now, in many cases, we'll consider it stable if it can be relieved by palliative measures. For instance, I have chest pain when I walk up a flight of stairs. When I stop walking up the flight of stairs, the chest pain goes away. Or if I stop halfway up, the chest pain goes away. Or I have chest pain when walking up a hill, but if I stop, the chest pain goes away. Or maybe I'm sitting in a chair and the chest pain begins and I take nitroglycerin, the chest pain goes away. So I take a medication and the chest pain goes away. That would be stable angina. Unstable angina would be different. It's something where it comes and doesn't go away. We try to give a dose of nitroglycerin, no change. Angina that occurs at rest that lasts longer than 20 minutes would be considered unstable. New onset angina, something that hasn't been typical, or under certain circumstances is now new. Crescendo angina would be crescendo being highs and lows, increasing in intensity or increasing in frequency or increasing in duration. Something that just used to happen for 1 or 2 minutes now occurs for 5 or 6 or 7 minutes. Or it now occurs with more increasing frequency times throughout the day. So these are characteristic of stable and unstable angina. And I like this figure illustrating the imbalance of oxygen supply and demand. And certainly in panel A, we see a normal oxygen supply for the given level of physical activity. Now, in a healthy person, if we have an increase in physical activity, heart rate increases, blood flow increases, respiration rate increases, ventilation increases, normal increased oxygen supply to meet the increased oxygen demand. No chest pain. Problem is with panel C is if we, during normal activity, aren't reaching and achieving the problem, if we have this decreased oxygen supply doesn't meet the level of demand, then we might end up with chest pain from the reduced blood flow to the heart. Decreased oxygen supply might mean that a person can't participate in normal physical activity anymore. Panel D says, look, they have to decrease activity. They can't do anything. And now we get to a point where panel E says that the decreased oxygen supply doesn't meet the body's basic needs. So not only were they, participating in normal activity and they had to stop the normal activity, but now it's not even meeting basic needs. And we have myocardial ischemia and chest pain that's resulting even at rest. These can all be problems, right? But understanding that acute coronary syndrome includes angina pectoris and myocardial infarction, we'll keep in mind, the part in red there, remembering that ischemia is caused by restriction in blood flow resulting in an imbalance of oxygen supply and demand. And certainly a number of causes, including the occlusion of coronary arteries, atherosclerosis, arteriosclerosis. We have this term called Prinzmetal's angina, meaning vasospasm that just spasms, and the spasming essentially occludes blood flow. So the spasming is essentially similar to the impact of a clot that's blocking an artery. Now, in many cases, Prinzmetal's angina can be resolved with palliative measures. So if we take, for instance, nitroglycerin, the spasming ceases, the pain stops. Stenosis, thrombus formation, these can all be causes of acute coronary syndrome. Now, obviously, we understand that in the instance of angina, there may be a need for emergency treatment. Patient now experiencing chest pain, especially during physical activity, should be asked to stop the activity, sit in an upright position. If we're able, and protocol allows, assist with administration of nitroglycerin, typically done sublingual under the tongue. Check pulse, respiration if we have oxygen and protocol allows, administering oxygen if necessary. Certainly, patients without a history of angina or those with a known history of angina may be treated a little bit different. Patient with known angina, we might provide a second dose. Patient without a history of angina, we may be transporting urgent to the ER to get checked out. We have some disease progression that occurs, so usually angina is progressive. Typically, it starts maybe small and begins over time to get worse. Talked about an acceleration in frequency and duration of those chest pain episodes, and certainly cell death, myocardial infarction, which we see being represented by this black area here. If this is where the occlusion occurred, everything downstream may not get adequate oxygenation, and myocardial infarction may occur. Now, here's what's important for us to understand. If somebody has an episode of chest pain, we don't treat that as, that's no big deal, it was just once. Because myocardial infarction may follow a single episode of angina. If we have a patient that says, I had chest pain, we need to get them looked at. Some other signs and symptoms that you may be all too aware of: pallor and diaphoresis, and nausea and chest pain. These all are signs and symptoms of angina pectoris. Myocardial infarction specific to cell death and necrosis of the heart muscle due to inadequate oxygen supply. Certainly, we understand that there are warning signs of a heart attack. That experience of pressure, heaviness, Some would describe it as, I feel like somebody is sitting on my chest. An elephant is just sitting on my chest, and no matter what I do, that pressure won't go away. I have this sense of burning in the chest. It feels like heartburn, but I know it's not. I haven't had anything recent to eat, or I've never had heartburn before. It feels like I have this significant discomfort. It feels like indigestion. Impending doom, anxiety, and fear. Certainly pain may occur, and if present, it's usually substernal. It's crushing, maybe even radiating to the left side, left arm. Can all be problematic and indicating signs of a heart attack. Myocardial infarction is going to depend on the size and location of the vessel involved. And I've already talked about this, so I won't labor this issue. But certainly if we're in the left coronary artery, if we look at an EKG, we see disruption of the electrical signal in different areas than if we're on the right coronary artery. So certainly if we have a recognition of the left coronary artery that's impacted, it may result in different areas of infarction. So by identifying on an EKG where these problems occur, that may help a physician who goes in to now do other diagnostic imaging to identify quickly what area they need to start their search in. And then obviously we have different indications on an EKG. So we use what's called STEMI, or ST elevation myocardial infarction. And so we might use this term STEMI and non-STEMI acute coronary syndrome. And then we use this term called transmural infarction. So a transmural infarction meaning across the wall, meaning that this infarction has been so significant that it's really incurred all tissues or all layers of the heart. And that may manifest with some different indication on an EKG. The way that the electrical signal may pass through certain areas and manifest may be a little bit different if it's just a subendocardial infarction. Okay, so immediate ST elevation gives us an indication there's an issue. But just because we have non-STI or non-ST elevation doesn't mean there's no angina, because we sometimes can't distinguish non-ST elevation from this problematic ST elevation. In other words, we don't see a high indicator, but there's still an issue there. So certainly complications from myocardial infarction, including sudden death and cardiogenic shock, congestive heart failure, rupture of necrotic tissue, cardiac tamponade, thromboembolism causing CVA. These are all issues. Now the goal here would be pain relief and reperfusion, getting to the ER, getting to the cath lab, obviously resolving the issue that's manifest. Now, when a patient is administered to the ER and their chief complaint's chest pain, I mentioned that certain enzymes may be elevated, right? And enzymes are proteins. Oftentimes you'll see different cardiac enzymes elevated in response to chest pain. Many times due to the disruption in oxygenation or ischemia that resulted. Sometimes due to the myocardial infarction or cell death that resulted. And so if we're looking at cardiac enzymes, a patient may be brought into the ER saying to the physician, I haven't felt well for 24 hours. I think I'm having a heart attack. Physician may quickly ask for a blood panel to identify, are any of these cardiac enzymes elevated? Maybe they'd previously had a heart attack that did resolve, and so when they walk into the ER, they get connected to the EKG, they see nothing. It looks normal. But if cardiac enzymes are elevated, it indicates maybe they did just have an episode. And in this figure, I like this, you can see cardiac enzyme changes with MI. Now, in the instance of a myocardial infarction, we may see some Q waves that are disrupted. We may see some slight changes on an EKG, but they may not be having an active significant disruption like tombstone ST elevation, for instance. We might see some indicators, but certainly some of the elevation of some of these may be like an onset of troponin or troponin I, or changes in myoglobin, or changes in lactate dehydrogenase, right? All of these can occur. So if we look at creatine phosphokinase or creatine kinase, that creatine kinase might indicate damage. And if we see a lot of CKBB indicating damage in areas of the brain, or CKMM or CKMB. So certainly if we see an elevation in CKMM, that may be as a result of muscle damage that's occurred due to working out, right? If a patient has been on a very high workout regimen, we may see damage of CKMM elevated in response to cellular damage. Eccentric exercise is going to cause some disruption in myofilaments and proteins in the muscle. So an elevation here may not be unreasonable if we have indication of why it may be elevated, but we probably shouldn't see elevations of creatine kinase coming from the heart. So in reality, when we measure creatine kinase, it should be fractioned, because CK alone tells you nothing specific about the heart. Like I said, it could be that a patient was engaged in a workout that caused muscle damage, and that creatine kinase would be elevated because of that. So keep in mind, right, the elevation of CKMB elevates in 3 to 4 hours post-MI. So, if it's something that's just happened, we may not see something, but if we keep the patient around in the ER, we do a follow-up blood eval in a couple hours, we may see some elevation there. More about lactate dehydrogenase. I'll just quickly talk through some of this, and we'll kind of move forward through some of these enzymes, because these enzymes aren't things that we're probably measuring in the field, but measuring mainly at the level of the hospital. So lactate dehydrogenase can be found in heart and skeletal muscle, as well as liver, kidneys, some tumors. It elevates in 90% of acute myocardial infarctions, but we could have false positives. So we might couple the measurement of lactate dehydrogenase with other things. Myoglobin, as an example, can be found in any striated muscle, heart and skeletal, often released following injury. Again, maybe gives us some false positives. So we tend to not measure one of these, but we measure a panel. Okay, we're measuring creatine kinase. We're breaking that apart to see, is it from the brain, the heart, the muscle. We're looking at lactate dehydrogenase. We're looking at myoglobin. Tends to peak 6 to 8 hours post-MI. And we're looking at troponin. And again, we have various forms of troponin as well. Troponin I is the cardiac and skeletal muscle protein family. It's part of the troponin protein complex. So typically where we have binding of actin to the myofilament, okay, holding that actin tropomyosin complex in place. Troponin I prevents myosin from binding to actin, okay, blocking that site. Troponin C we're familiar with, right? Calcium binds to troponin, causes a conformational shift in tropomyosin. Right, so troponin C is the calcium binding protein subunit that initiates a sequence of conformational change in the thin filament. So we might, again, as we ask for a blood panel, identify troponin, but maybe specifically looking at troponin I. And in some cases, troponin T has also been indicated to be one that we may also want to be aware of in terms of myocardial infarction. Elevating in 4 to 6 hours, peaking in 12 to 16 hours post-MI. So diagnostic tests, changes in ECG, serum enzyme, isoenzyme levels, looking at myosin and cardiac troponin levels being elevated, looking at leukocytosis, elevated C-reactive protein, and erythrocyte sedimentation rate. Sedimentation rate can be indicative of how well, when we draw blood, how well the red blood cells settle, and a faster sedimentation rate could indicate inflammation. Changes in that rate are going to be indicating to us different ailments that could be present. So when we couple all of these diagnostic tests together, independently they may not mean a whole lot, but as we start to put one thing together with another, the puzzle pieces all start to come together. We've talked about arterial blood gas measurements. I'll move forward from there. And then pulmonary artery pressure measurements may be helpful in terms of indicating how well blood is able to circulate throughout the body. So a lot of these different changes may be coupled again in terms of diagnostic techniques, but treatment may include medications, reperfusion therapy. In some cases, patient is experiencing arrhythmias, pacemaker may be necessary. If a patient has, dysfunction of the atria, they might have to have pacemaker placed so that it senses, when there's no signal from the atria, the SA node, the pacemaker is going to say, hey, I didn't sense a signal from the SA node. Oops, that's okay. I'll take over, and the pacemaker will fire and act as the SA node, as an example. Now, the pacemaker can sense different areas and also cause different areas to fire. So the activation of the pacemaker may be placed in the atria to cause the atria to contract, may be placed in the ventricle, causing the ventricle to contract, right? So a lot of different things. And then certainly further treatment, you can read there a lot of the medications and the reperfusion therapies, but also cardiac rehab programs are going to be advantageous and necessary for patients who are seeking to return to an active lifestyle or return to activities of daily living. So all of these would be very important as we go forward. Okay, looking at cardiac arrest. Okay, pathophysiology. Patient obviously a little bit different from myocardial infarction, where we had ischemia resulting in tissue death, but now we're talking about cardiac arrest. No conduction of impulse, no heartbeat, no blood flow. Patient is unconscious, unresponsive, flatline EKG, as an example, right? That'd be an arrhythmia. No pulse. Begin CPR. The reality here is a chance of survival from cardiac arrest decreases for every minute that we're hands off. Patient goes down. For every minute that CPR is not initiated, survivability reduces 10%. Meaning if we have a patient who goes down for 3 minutes, their chance of survivability has reduced 30%. Now, folks, at some point we recognize that survivability doesn't mean recovery with full function. If survivability because a patient was unresponsive, unconscious, and had no CPR for 5, 6, 7 minutes, survivability may be 30, 40%. Maybe they survive, but the amount of time the brain was without oxygen may mean that they have significant damage cognitively. So should somebody go down, be ready to respond, get the AED. Electrical therapy is hugely advantageous, but most advantageous is push hard, push fast, circulate blood to the working brain and muscles, get the blood circulating around. So our etiology: excessive vasal nerve stimulation, potassium imbalance, cardiogenic shock, drug toxicity, insufficient oxygen, respiratory arrest, trauma to the heart, all the above causing problems. So I want to frame our current understanding. And I want you to get, we're going to move into heart failure. And as we move into a discussion of heart failure, I want you to think about the system in reverse. Let's walk through the system how we know it. Okay, superior inferior vena cava. This is moving forward. Okay, blood enters into the right atrium, travels through this tricuspid valve into the right ventricle. Deoxygenated blood is pumped out via the pulmonary artery to the lung, where at the capillary bed gas exchange takes place, oxygenating our blood, returning via the pulmonary veins back to the left atrium, through that mitral valve or bicuspid valve into the left ventricle, and out this aortic valve into the aorta to the systemic circuit, including the brain, other organs, tissues, muscle. At the capillary bed, gas exchange takes place and deoxygenated blood returns to the right atrium. Okay, that's our normal flow. Got it? We've seen this before. But now I want you to think to yourself, about the system in reverse. In a moment, I'm going to introduce to you left heart failure. Left heart failure. Failure of the left ventricle. And I've asked you to think about the system in reverse. If the left ventricle is impacted, we are going to have problems backing up into the system. Follow the system in reverse. If we have left ventricular problems, we might end up with issues in the left atrium. If we have left ventricular problems, those issues of the left atrium may progress to issues in the lungs. If we have issues in the lungs, those issues in the lungs may progress to problems in the right ventricle. Problems here in the right atrium, problems here causing dysfunction in return of blood flow. Congestive heart failure, you may be familiar with a backup of blood causing pitting edema, reduction of blood flow back to the heart. So think about the system in reverse, okay? And how the dysfunction may manifest. Okay? All right, let's do it. Let's look at left heart failure. Now, left ventricular failure, the pathophysiology here is it results in an increase in back pressure into the pulmonary circulation. Because of left ventricular failure, the heart is unable to pump out sufficient blood to meet the metabolic demands. Because of the abilities of the left ventricle, because of the inability to pump blood out, the pathophysiology here is a resulting increase in back pressure. Why? Well, maybe it's because of myocardial infarction. Maybe it's because of valvular disease. Maybe it's because of chronic hypertension. Maybe it's because of dysrhythmias. It's usually a complication of another cardiopulmonary condition. Left heart failure doesn't typically manifest first. Typically something else, some other type of cardiopulmonary condition precedes it. You can see from this figure, zoom in here, left heart failure signs: cyanosis and tachycardia, noisy labored breathing, rales, coughing, blood-tinged sputum, gallop rhythm of the heart, difficulty breathing, right? All the above from left heart failure. Right heart failure. Right heart failure results in an increased back pressure into the systemic venous circulation. Think about the system in reverse. If we have right heart failure, this results in an increased back pressure into the systemic venous circulation. So what happens? We have swelling that occurs in the feet, the ankles, the legs, that pitting edema, characteristic. Blood backing up now also into the stomach, the liver, causing this abdominal distension. Now, what's typically the cause of right heart failure? It's left heart failure. See, left heart failure causes a backup into the pulmonary or into the pulmonary circuit. Left heart failure backs up, think in reverse, into the lungs, creating a high pressure of flow in the lungs, such that there's now a greater pressure in the lungs that the right heart cannot overcome. The right heart fails, and because the right heart can't efficiently move blood into the lungs because of the buildup in pressure, because of the back pressure from the left heart failure, the right heart failure backs up. And where does it back up to? It backs up in the venous system of the systemic circuit. Again, causing some of those problems. I'll zoom in here. Right heart failure, signs: tachycardia, neck veins engorging or pulsating, distending, edema of body and lower extremities, engorged liver and spleen, abdominal distension or ascites. All the above from right heart failure. And then congestive heart failure. Here we have a pathophysiology. We're talking about congestive heart failure. It's a reduction in the heart stroke volume, causing fluid overload throughout the body's other tissues. Folks, the heart's just not able to circulate blood like it used to. Cardiac output, stroke volume, both decrease. Less blood reaches the various organs. The heart's failing. This congestive heart failure is decreasing cell function, fatigue, then lethargy, and patients feeling lethargic as a result of reduced oxygenation. Could have, in some cases, mild acidosis develop. It's a backup in congestion that develop as coronary demands for oxygen and glucose are not met. So all this is happening together. Now, output from the ventricle tends to be less than inflow of blood. So we have this congestion in the venous circulation that's draining into the affected side of the heart. Now, what would be the cause? In the acute setting, could be from pulmonary edema. Pulmonary edema causing a backup into the right side. Pulmonary hypertension, myocardial infarction, right? All of these causing congestive heart failure where the right side now begins to fail. Think about a backup. Pulmonary edema, pulmonary hypertension, creating a high afterload or pressure that the right heart must overcome. So if we're thinking in reverse from the pulmonary circuit, directly before that was the right side. If the right side fails, we now have congestion in the venous circulation, which is draining into the right side. It's in the acute setting. In the chronic setting, cardiomegaly, an enlarged heart. Left ventricular failure in the chronic setting. Think about left ventricular failure in the chronic setting. Left ventricular failure causing a backup into the left atria, causing a backup into the lungs, causing a backup into the right side of the heart, causing congestion in the systemic circuit. And then certainly in chronic setting, right, it may be from right ventricular failure, right, which can be right ventricular failure can be caused from other things. So in an acute setting, it may simply be because acutely we have pulmonary edema, pulmonary hypertension that just manifest, and because of those, very quickly we have congestive heart failure occur. In the chronic setting, it takes some time for these failures to develop, and these failures develop as a result of other cardiopulmonary issues. But if we have these heart failures, then ultimately they cause congestive heart failure. Let's walk through this figure here. Zoom in. Okay, we have an example of myocardial infarction in the left ventricle causing a loss of heart muscle, which results in decreased cardiac output. And we can see that as a result of decreased cardiac output, if we continue to follow this path, we have to activate compensatory mechanisms, stimulating the sympathetic nervous system. And we might have vasoconstriction, which helps to facilitate increase in blood flow. We have a change in the chronotropic and inotropic components. So we increase the heart rate, chronotropic, and increase the force, inotropic, which increases, again, myocardial work, stimulating the renin secretion, leading to activation of angiotensin vasoconstriction, stimulation of aldosterone secretion, trying to increase and retain water to increase pressure to facilitate movement of blood out the system. Now what happens is that if we have a decreased cardiac output, the body is trying to undergo all these compensatory mechanisms. The problem is compensation to maintain cardiac output ultimately fails and leads to decreased cardiac output, and leads to further decreased cardiac output, leads to further decreased cardiac output as we cycle around that series of events. So we try to break the cycle of decreased cardiac output requiring compensatory mechanisms to compensate. So if we can treat and prevent the heart from having to continue to compensate, ultimately leading to failure and breakdown and further reduction in cardiac output, then hopefully we can prevent some of the heart failure that results. And you see oftentimes the treatment to break the cycle is in response to medication. Now let's say ultimately, we have these decrease in cardiac output, compensations maintain cardiac output for a time, but ultimately the maintenance of that cardiac output fails because of a continued decrease. The heart muscle in the left ventricle weakens. It can no longer compensate. And the left ventricle doesn't fully empty now. So if we look at ejection fraction, we now start to border on heart failure. See, if we look at an ejection fraction, how much blood moves out versus how much came back to the heart, it's going to tell us the percentage. So we should have, 70% of that moving out. But now if we have an ejection fraction down at 30%, where of the blood that came into the left ventricle, only 30% left, the left ventricle doesn't fully empty, decreasing cardiac output, blood backs up in the pulmonary circulation. Thinking about the system in reverse, causing pulmonary congestion. Now this, if we're thinking in reverse, increases resistance for the right ventricle. And if pulmonary congestion increases resistance for the right ventricle, then the right ventricle weakens and can't fully empty, causing a blood backup into the systemic circuit or right-sided heart failure, resulting in edema in the legs. So you can see here that edema in the legs may not have been immediately following myocardial infarction, but because of some of the cell death and the inability for that heart to adequately pump blood out to the system, over time we have a development of left-sided heart failure and then right-sided heart failure, and then this is ultimately what we may see. So here's some of the effects of left-sided congestive heart failure. The left ventricle weakens and cannot empty, which means we have a decreased cardiac output to the system. Decreased renal blood flow stimulates that renin-angiotensin and aldosterone secretion. Backup of blood in the pulmonary vein, high pressure in the pulmonary capillaries leads to pulmonary congestion or pulmonary edema. So all of these causing problems. So some of the signs and symptoms of left side heart failure, obviously being pulmonary congestion, but if we have pulmonary congestion, a sign or symptom of left-sided heart failure may also include difficulty breathing, so dyspnea or orthopnea. And we might be talking about a cough, perhaps associated with fluid that's irritating the respiratory passage, or paroxysmal nocturnal dyspnea. Or maybe we're talking about acute pulmonary edema, right, causing some of this nocturnal difficulty breathing. And the paroxysmal kind of being this temporary state, comes and goes. Nocturnal, sleeping, difficulty breathing. And excess fluid in the lungs frequently leads to other infections such as pneumonia. So all of these can be problematic. We have some compensatory mechanisms to fight or combat some of this, like tachycardia, cutaneous and visceral vasoconstriction, right? Daytime oliguria, so decreased production of urine to hang on to fluids, all to compensate for left side heart failure. Now, we have effects of right side congestive heart failure. So here, the right ventricle weakens as it can't empty. decreases cardiac output overall to the system. Decreased renal blood flow stimulates renin, angiotensin, and aldosterone secretion. We've seen that from the left side. But ultimately, right side congestive heart failure leads to a backup of blood into the systemic circulation. An increase in venous pressure results in edema in the legs and liver and abdominal organs, and a very high venous pressure causes distended neck veins and cerebral edema. So now we're talking about right side heart failure that causes a backup into the system, causes problems and damage to some of the organs, as well as distended neck veins and cerebral edema, swelling in the brain. So some of the signs and symptoms we might see on right-sided heart failure might be dependent edema in the feet, legs, buttocks, increased pressure in the jugular veins leading to JVD or jugular vein distension, an enlarged liver, enlarged spleen, ascites, which is complications of fluid accumulation, kind of a characteristic of abdominal distension, flushed face, distended neck veins, headache, visual disturbances, folks, all of these from heart failure. I like this figure. You can pause the video, you can read through some of this, but looking at some of the left side, right side differences, causes, basic effects, signs and symptoms. You can pause this and look through this at your leisure. Young kids with heart failure, typically as a result of some type of congenital heart disease. We don't tend to see congestive heart failure in healthy kids, but often secondary to congenital heart disease. One of the first signs might be feeding difficulties, failure to gain weight or meet developmental guidelines, short sleep periods. Child might also assume this tripod position, and by leaning forward, they're trying to alleviate some of the pressure or stress that they're feeling in the chest cavity. They may have a cough, rapid grunting respirations, flared nostrils, wheezing, certainly showing an enlarged heart under diagnostic imaging. And then we might look at arterial blood gases to measure hypoxia to see how well the body is circulating oxygenated blood. So given some of this may be a result of congenital heart defects, let's take a moment and chat about some of these. If we look at cardiac anomalies, we're talking about structural defects in the heart. Now typically cardiac congenital heart defects being something that's developing as a child is in the womb. And some of the congenital heart disease that we may see could be valvular defects, septal defects, could be detected upon birth by presence of a murmur. But we need to understand or recognize that some of the congenital heart problems, if untreated, can lead to bigger problems like heart failure. Certainly if we are recognizing a child who's cyanotic, that could be dependent on oxygenation status. Could be acyanotic, but it depends on direction of shunting, and this is oftentimes a result of some type of septal defect. Now, diagnostic testings may include a number of different examination techniques, but ultimately identifying one of these congenital defects is going to allow for some type of surgical repair. And the figure that I placed on the screen is just to illustrate what may be seen in terms of a mitral valve looking very occluded or stenosed and being replaced with the technology that we now have for going in and doing some type of surgical repair, so a mitral valve replacement. We also have ventricular septal defects that could occur, most common congenital heart defect that we may see. And it's essentially where if you consider the heart, right, we have the right and the left side, and an opening in the interventricular septum between the ventricles causes the problem. Because if you have an opening in the interventricular septum, that means blood is leaking from one side to another. If blood that is deoxygenated is leaking into the left ventricle, what are we circulating around the body? If deoxygenated blood from the right side leaks into the left side, then we're circulating deoxygenated blood combined with oxygenated blood. That's where we might have a patient who's cyanotic. We might have untreated ventricular septal defects, things that we may, not necessarily recognize, and it may go untreated for long periods of time because we may not be aware of it because some of the signs and symptoms aren't indicated. Now, in untreated ventricular septal defect, pressure is usually higher in the left ventricle, but may not be manifesting with problems. Now, the shunt that I described a moment ago was right-left shunt. But shunt left to right may not be as much of a problem, so it may be untreated. Because if we have, think about the left to right shunt, if we have oxygenated blood that's already been oxygenated leaking into the right side, then there's really not a lot of issue because oxygenated blood leaking into the right side is being pumped where? It's being pumped to the lung to be oxygenated. In this case, a cyanotic condition. Okay, cyanosis wouldn't be present because we're not having any disruption of left ventricular blood that's oxygenated being pumped throughout the body. Now, it could be a problem if a lot of blood is leaking, where we have now a decrease in cardiac output. So a cyanotic condition, unless respiratory condition increases pressure in the right ventricle, and then we had some backups in the system, which could be then problematic. But if we look at some of the treatment of ventricular septal defect, obviously surgery and other indications for catheter procedures or some type of hybrid between the two. Medical, okay, looking at an increased strength of contraction, decreased amount of fluid in the circulation, keeping a regular heartbeat. So depending on the type of shunt, right, depends on the severity and depends on the need for intervention. We have some other defects that may be present. Okay, usually they affect the aorta and pulmonary valves. May be classified as stenosed or just valvular incompetence. So a failure of the valve to close completely or a blockage of the valve, right, could also be problematic. So if we have a valvular incompetence, that could be indicative of blood regurgitating or leaking backward in the system. Something like mitral valve prolapse, which we talked about already, may require some type of surgical replacement. We saw a figure of that on the other slide. I'm gonna move through because we've spent a lot of time already talking about this here, but you can pause the video and look at the difference between normal, stenosed, and incompetent valves. But we've really highlighted all this already. Tetralogy of Fallot. Most common, cyanotic right-left shunt, meaning we're moving deoxygenated blood into the right side, into the left side, pumping out to the systemic circuit deoxygenated blood. In fact, this is what we see in this figure right here. So here's this interventricular septum where we have a defect, and instead of deoxygenated blood pumping to the lung, deoxygenated blood, some of it pumps to the lung, but some of it leaks into the left side, so that when we pump out blood to the rest of the heart, we have deoxygenated blood mixing with oxygenated blood, meaning that instead of having 98.5 arterial oxygen saturation, now we have less than that, right? How much less? Well, that's going to be dependent on how well the person is able to function with this particular defect. If it's to the point where it's causing cyanosis, we're probably less than 70%. In terms of arterial saturation, if we were to take that volume of blood as a whole. So cyanosis occurs in this case because the shunt bypasses the pulmonary circulation, alters pressure in the heart, alters blood flow, and this tetralogy of Fallot includes 4 abnormalities. Number 1, stenosed pulmonary semilunar valve. Number 2, ventricular septal defect. Dextroposition of the aorta, meaning we might have some alteration of how the aorta, is positioned and impacted, meaning that some of the blood may be moving actually from the right ventricle directly into the aorta. And right ventricular hypertrophy could manifest as a result of stenosis of that pulmonic valve, because if we encounter pressure, if we encounter resistance to moving blood out of the right lung, then we have a pressure that builds up, and the right side of the heart compensates by growing stronger. And right ventricular hypertrophy could be positive in terms of compensating, but to a point, because at some point it's going to become incredibly negative, and that compensation where the right side of the heart grows now is causing problems of receiving blood and adequately, getting blood out of the system. So certainly right ventricular failure could be on the horizon. So this figure is nice. It illustrates, stenosed pulmonary valve, and it illustrates aortic emerging from both ventricles, so that dextra position that I talked about, intraventricular septal defect and large right ventricle, all as a result of tetralogy of Fallot. Cardiac tamponade, another issue that we want to be aware of as we're talking about cardiovascular pathologies. Looking at the epidemiology and pathophysiology of cardiac tamponade, we're looking at a resulting fluid accumulation between the visceral pericardium and the parietal pericardium. Now, this increased intrapericardial pressure impairs diastolic filling. In other words, if we're adding fluid around the coverings of the heart, that added fluid creates resistance. So typically, this condition is going to worsen until it's progressively corrected. So normally we don't have a lot of fluid around the heart, 25 mils. Okay, acute cardiac tamponade, we might have 75 mils or more. Now, as that continues to progress, at some point, pericardial synthesis may be necessary, where a physician may go in with a needle and actually remove some of the fluid with a syringe. Epidemiology here, acute onset, typically the result of trauma to the heart or myocardial infarction. We could have benign presentations that may be caused by cancer, pericarditis, renal disease, and hypothyroidism. So if you have a field assessment of patient history, we're looking and trying to determine precipitating causes, what may have been occurring first. Patient relates a history of difficulty breathing. We're looking at now an exam and looking at a patient who has a rapid and weak pulse, decreasing systolic pressure, narrowing pulse pressures. So talking about, narrowing pulse pressure would be systolic and diastolic difference narrowing. Pulsus paradoxus, talking about different strengths of some of these pulses as we're moving through. And so pulsus paradoxus could be a very large decrease in some of our systolic blood pressure, kind of a fall of maybe even as much as 10 millimeters of mercury. And so referred to, this change that occurs over time. Faint muffled heart sounds, jugular vein distension, the 3 in red, Beck's triad, and electrical alternans, where in this case we have less than normal voltage of waveforms in every other beat. And so this would be an example of electrical alternans, where we see a large waveform, a small waveform, a large waveform, a small waveform, large waveform, a small waveform. So this would be electrical alternans. And rheumatic fever, rheumatic heart disease, which has been addressed in some other lectures, but looking at rheumatic fever, an acute systemic inflammatory condition. Now, typically, rheumatic fever manifests as a complication, a sequelae of other disease. Can occur a few weeks after untreated infections, like strep. Rheumatic fever involves the heart as well as joints. Oftentimes we're seeing this in kids age 5 to 15, so this could be the onset and somewhere in a high school athlete. Long-term effects, rheumatic heart disease, may be complicated by infective endocarditis and heart failure in older adults. So in this acute stage of rheumatic fever and rheumatic heart disease, we have inflammation of the heart. Right? We're talking about some type of inflammation. Maybe it's of the pericardium, maybe it's of the myocardium, maybe it's in the endocardium. Okay, we're talking about pericarditis, myocarditis, and endocarditis. Maybe we have incompetent heart valves where we have a leaking or movement of flow of blood retrograde. We could also, in this rheumatic fever, have other sites of inflammation, large joints, different tender nodules, jerky movements, and erythema marginatum or marginatum would be this type of pink rings that may occur, and typically occurring on the torso and inner surfaces of limbs. These can be problems that, this ring of redness, or obviously indication of red blood cells. So one of the things that we may look at when we see this rheumatic fever manifest maybe into rheumatic heart disease would be some of these signs and symptoms. So we look at our athlete talking about low-grade fever, leukocytosis, generally just not feeling well, fatigued, tachycardia, heart murmurs, epistaxis, abdominal pain. Being very kind of challenging, problematic if we're referring to some of these ailments. And certainly with some of our valvular problems, looking at low-grade fever and very similar signs and symptoms to what we saw. So how are we going to diagnose some of our rheumatic fever? Elevated serum antibody levels. We'll look at heart function, electrocardiography, ASO titer, which would essentially be an anti-streptolysin test to determine if a strep infection was previously present. So also, recalling that strep may present complications or manifest into this, so identifying whether strep was present. Treatment, prophylactic antibacterial agents, anti-inflammatory, looking at this development that we see of rheumatic fever and rheumatic heart disease, obviously looking at this strep that was present. Now obviously if we have recovery of strep and strep is identified early on, no issues, right? But it's the area where we have some type of antecedent infection that manifests, where antibodies are formed, antibody collagen reaction occurs, causing inflammation of the heart. So if we don't resolve issue 1, then issue 2 develops. In this case, rheumatic fever and rheumatic heart disease. So now we have inflammation of the heart, which manifests as pericarditis or myocarditis or endocarditis, and could result in scar tissue, loss of valvular functions, and arrhythmias, leading to rheumatic heart disease. So all of the following we want to keep in check, and certainly preventing some of the initial infection helps to alleviate some of the complications that may manifest. Real quick, I want to talk about infective endocarditis. Again, we see strep and we see staph, okay, being some of the infections that may precede problems in the heart. Okay, so basic effects the same regardless of the organism. Factors that predispose to infection would be presence of abnormal valves. So somebody that has strep or staph infection and has predisposing factors could be at risk for infective endocarditis. Similar to what we saw with rheumatic fever would be this low-grade fever and fatigue, seeing anorexia, enlarged spleen, congestive heart failure. Acute endocarditis could be sudden marked spiking fever, chills, drowsiness, subacute, an insidious onset, fatigue, anorexia, cough, dyspnea. blood culture to identify the causative agent, so what was present that maybe led to this. And then pericarditis is another component to talk about, as we have addressed some of the inflammatory markers, but looking at usually pericarditis being secondary to another condition. So classified by the cause or type of exudate, so this would be an analysis of some of the fluids to identify, where this problem is occurring. Acute pericarditis being a simple inflammation of the pericardium, and it could be as a result of, again, other conditions, for instance, that manifest after open heart surgery, following a myocardial infarction, aligned with rheumatic fever, systemic lupus, erythematosus, so lupus if we're shortening that, cancer, renal failure, trauma, viral infection. And then one of the problems from acute pericarditis could be effusion that develops. An effusion, pericardial effusion specifically, would be a large volume of fluid that accumulates in the pericardial sac. We've talked a little bit about that challenge already, but certainly if we had a bolus or a volume of fluid surrounding the sac, that could cause a problem with the heart being able to function and operate normally, because it can't maybe distend like it normally would. So it can't fill like it normally would, which would maybe cause a backup in the system. Perhaps a backup in the systemic circuit, leading to distended neck veins and faint heart sounds and pulsus paradoxus, as we've talked about. So some of the effects of pericardial effusion being fluid around the heart, so the heart can't expand and fill, back up into the systemic circuit, decrease in blood flow to the lungs, decreased output to the body. Now, in a chronic sense, this might result from adhesions between the pericardial membranes. Fibrous tissue often results from tuberculosis or radiation to the mediastinum, as would happen during some type of treatment, perhaps for cancer. Limiting movement of the heart during diastole and systole, reduced cardiac output, all being problematic in a sense. So cardiac pericarditis causing some significant problems, leading to disruption of cardiac output, causing fatigue, weakness, abdominal discomfort, all the above. So a lot of different manifestation of some of these problems. Now, we'll kind of wrap with hypertension. I think we've got a few more slides after this, but kind of finishing with wrapping up with some of our cardiovascular heart problems. Now we'll move into some of the vascular components. But looking at heart disease might manifest first with hypertension. So we might first identify some vascular problems that lead to causes or changes in afterload, which manifest with changes at the level of the heart. So we see the new blood pressure guidelines that were released in 2017, kind of adopted and now being circulated into this normal, elevated, and hypertensive category. You'll notice prehypertension is no longer one of the categories of blood pressure. And this figure illustrates the development of hypertension and some of the acute causes that may occur, including decreased blood flow to the kidney, increase in renin secretion. We've talked about that already, and how some of those may manifest into compensatory mechanisms, okay, where these compensatory mechanisms, okay, which lead to systemic vasoconstriction and aldosterone secretion in an effort to kind of compensate, okay, increased peripheral resistance and increased blood volume, causing an increase in pressure. Now, that increase in pressure may be advantageous in some cases to ensure that blood flow is adequate to the rest of the body. But the problem is that over time, that increase in blood pressure can damage a number of different areas. And you see that illustrated here. So not only that, we can have damage to renal blood vessels and also causes increase in afterload, which increases the work that the heart has to do, which could result in left-sided heart failure. And then just think about that system in reverse. Left side heart failure, talking about enlargement in the left atria, maybe looking at backup into the pulmonary circuit, into the right side, and then congestive heart failure with the congestion in the systemic circuit. So a lot of different things, but uncontrolled hypertension certainly can be problematic for areas of the brain, the eyes, the heart, the kidney, and the blood pressure. Negative impact on all the above. Definitely want to get high blood pressure under control. Far too often, a younger population may say to themselves, well, I'm young, it doesn't matter. High blood pressure is not a big deal. No, that's not true. Couldn't be further from the truth. The effects of uncontrolled hypertension could be catastrophic. They could be incredibly problematic. Now, frequently, they may be asymptomatic, right? And this is why a younger population may say, look, it's not that big of a deal. Because in the early stages, we may not notice a bunch of problems. But as a person gets older and that heart has to continually compensate for hypertension, we might start to see initial signs. These might be vague and nonspecific, but fatigue and overall poor sense of feeling, sometimes a morning headache. Essential hypertension can be treated, obviously, with lifestyle changes, reduction in sodium intake and weight reduction, and decreasing stress, certain drugs. And then we have secondary hypertension, which may result from other things like renal or endocrine disease. Underlying problem in that case should be treated to help with blood pressure. So we have to determine, is it something that's primary or secondary, and what do we need to be treating first? Because if we treat the symptom, we may not resolve the cause. Peripheral vascular disease, okay? Disease in arteries that are outside the heart, peripheral, okay, vascular disease. Increased incidence in those patients with diabetes, so keeping an eye on athletes with predisposing conditions or increased risk factors. Most common sites where we have peripheral vascular disease, which would be in the abdominal aorta and carotid arteries, femoral and iliac arteries. And these can be identified with diagnostic tests of blood flow, which can be assessed by Doppler, which we talked about early on, arteriography, plethysmography, measuring the size of limbs and blood volume, okay, in different tissues, and we can also look at oxygenation status. So a lot of different methods of diagnostics, but then certainly signs and symptoms, things that you're going to notice, again, fatigue and weakness and claudication, where a person now is experiencing leg pain as a result of this vascular complication, associated oftentimes with exercise. So as a person begins to exercise, if they have this peripheral vascular disease, oxygenation is inadequate in muscles that are distal to that block, and as a result in muscle ischemia and pain. So that may be the first sensation that an athlete experiences, is undue muscle pain for no specific reason, right? They increase their physical activity, did not sustain any acute injury or contact, but are experiencing this muscle ischemia and leg pain as a result. Might also couple that with a sensory impairment, tingling, burning, numbness, right? Could be problematic in those cases. Peripheral pulses, distal to the occlusion, may be weak. This may also be necessary, in terms of diagnostic, where we use ultrasound to identify, is there blood flow in the, pedal pulse? Is there some type of occlusion in the leg that's reducing blood flow to these areas? How's the skin look, right? Marked pallor or cyanosis, skin's dry, hairless, toenails thick and hard because of decreased oxygenation. Maybe we need to look at treating this peripheral vascular disease. So how can we do treatment? Well, a number of different areas there. I won't read them all. You can read these for yourself, but certainly treatment could just be resolving the cause. So maybe the control of blood pressure or blood glucose, or if a person's overweight or high cholesterol, maybe controlling the cause is going to alleviate the symptom. Okay, so a lot of different things that can be done here in terms of treatment. Looking at some other vascular problems, aortic aneurysm. So this would be a weakening of the arterial wall, causing localized dilation, and that can be incredibly problematic for the ability of blood to be circulating throughout the body. And in some cases, if we look at an aortic aneurysm, we may find that there's some type of defect in the medial layer, where if we end up with some type of weakening, then blood is essentially going to cause a bulge or an enlargement of this particular vessel. Now, there are different shapes or types of aortic aneurysm. Fusiform, where we have circumferential dilation along a section of the artery. Okay, saccular, where it's not the entire bulge, but now it's just an area or bulging wall. And then this is incredibly problematic, dissecting aneurysm, is where there's a tear in the intima, which would be the interior wall. So fusiform, saccular, and dissecting aneurysms, and we see some pictures of what that looks like and how that might manifest if we were to do some diagnostic imaging. This is essentially what would be found as we were looking at the vessel wall. And we saw a great example when we looked at the ultrasound as to how that vessel wall looked. Aortic aneurysms could be caused by other vascular problems. Atherosclerosis is an example. Could be caused by trauma, syphilis and other infections, or some type of congenital defect. So some of the signs and symptoms that we might see: bruit may be heard on auscultation of the area. The pulse may actually be felt. Okay, if we're feeling in an area, we may actually be able to palpate different. In the case of an abdominal aortic aneurysm or AAA, we might have a pulse that may be felt on palpation. Frequent asymptomatic until they become large or rupture, and the rupture can lead to moderate bleeding, and could cause death depending on the size and location of the aneurysm. So here would be an abdominal aneurysm, and here we have a picture of that abdominal region, and you can see here that large mass that has developed. So we might have some techniques in terms of radiography and ultrasound. CT scanning and MRI could help to identify some of the movement, and imaging could be coupled with some type of contrast dye to help to illustrate where some of the largest problems result. Now, in terms of treatment, maintaining blood pressure is going to be number one, because if we have an elevation or high blood pressure, that can cause a rupture or further complications, or create an increase in progression of this problem. So preventing sudden elevations in blood pressure, especially those caused by exertion, so might have to reduce physical activity until we get something repaired. Preventing stress, coughing, constipation, things that would be elevating particular pressures, and surgical repair would be necessary in some cases. Many of us have heard of varicose veins. And we know that characteristic of varicose veins, as we see in the figure there, would be irregular, dilated, these tortuous areas that are, they're not this normal, nice, straight line vein, but rather they're this very unique structure that doesn't look as smooth as a vein normally would. And this is often in response to incompetent valves or leaky valves that are causing blood to flow retrograde in the wrong direction. Increase in BMI, okay, parity, or referring to pregnancies up to a viable gestational age, so the number of times we've been pregnant and had a child, that could result in an independent elevation or risk factor for varicose veins. Weightlifting, those would be in areas of increasing risk as we're adding to the pressure in certain areas. Typically occurring in the legs, may develop from a defect or weakness in the vein wall, and often appear as these irregular purplish bulging structures. And so you might see some people wearing some type of compression stockings to help and aid in blood flow returning up. Now, these could be very painful in some cases, may need to be surgically removed in others, and certainly we have a number of complications that could result if we have vast varicose vein throughout the leg, because if we have incompetent valves, that's going to reduce the blood that's returning to the heart. So it reduces some of that venous return, and that can be problematic in some degree. Thrombophlebitis and looking at some of the challenges that we have in terms of inflamed veins. So looking at a thrombus that may develop could be due to some type of surgical procedure or some type of medical procedure like an IV that just becomes inflamed as a result. Some other factors for thrombus development: stasis of blood or sluggish blood flow. So if we don't have adequate oxygenation or tissue blood flow, that could cause clots to develop. That could be problematic. If we had trauma or other type of endothelial injury, that could cause a thrombus to develop. And increase in blood coagulability. If we had some problems in terms of recent surgery, like a lower leg surgery, that could cause at that site clot to develop. The clot could break off, and that could be problematic with a clot that's now circulating throughout the body. That clot gets to the lungs, problematic. The clot gets to the heart, again, problematic. So some of the signs and symptoms that often times these go unnoticed, but a lot of times, if you have some type of phlebitis or inflammation of the vein or thrombosis due to phlebotomy or something like that, a clot could cause some aching and burning and tenderness in the affected area. Systemic signs, if significant, could be fever, malaise, and leukocytosis. And then obviously complications, as I already mentioned, pulmonary embolism, or if clot were to make its way to the heart, could cause some problems in terms of myocardial infarction. So some treatments here would be preventative measures: exercise, elevating the legs, reducing some of the ability for that clot to manifest. Anticoagulant therapy could be advantageous in terms of if clots are developed, trying to help break those up. And then surgical intervention could be in some cases necessary. So with that, we'll conclude the discussion here of some of the cardiovascular components, and I thank you all for your attention.